Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn McMakin. You're all set.
Great. I'm all set to be by myself for a little while.
That's right. Do you have stuff to talk about for 20 minutes until Carol gets in?
I always have stuff to talk about. I feel like it's like my turn to talk uninterrupted for a little bit.
Okay.
But yeah, I do have actually so much to talk about. 2 out of 3. That's right, Leaf. 2 out of 3 of us are here. Carol apparently is stuck in traffic. She also texted me that she's going to be 16 minutes late, so I will do my best to keep everybody entertained for 16 whole minutes. It's funny, as I was getting everything ready for today, I had my stack of favorite books. So maybe I'll do a little bit of a book report before we get going. But I also wanted to answer a couple really easy questions that I'd been emailed. So this should be great.
Go for it.
Good. All right.
I'll just sit here.
You'll just sit here and take all the information in. And it's funny, we both have our microphones. We're all ready. I just want to get sure my computer is set here. Okay. So first of all, I was emailed by somebody who has taken the core and the advanced, my courses, and was really confused about polarity. And I had to read the email a couple times because I thought that is one thing that I think we take for granted, that everybody knows the polarity, but maybe not. So if one person has a question, maybe there's more. Which gives me a very organic segue into one of my favorite books. I'm going to pull it out because I have it all on my lap right now. The Body Electric. You will see this book at every conference, every core, every advanced meeting. Robert Becker did an amazing job cutting parts of salamanders off and hooking them up to current to see if they could grow arms and legs and tails. This book probably took me a little over 2 years to read. I find it extremely dull and boring and dry. I'm sorry, Robert Becker, you are like a plethora of knowledge, but this book is dense. It's very heavy. But at the advanced this last year, Juliana Mortensen did an amazing presentation. So those of you who are practitioners and have access to our advanced compendium, please look at her presentation because she talks a lot about the early years and those early slides of polarity. And just to really summarize it, to keep it very simplistic, Robert Becker's research proves it. Like our brain, heart, and spinal cord are polarized positive. So we always want to put the positive leads closer to our brain, spine, and heart. And I'm sorry if we have rushed past that in the past. I actually made a big slide of it for this weekend's past sports course so that we all keep that in mind: brain, heart, and spinal cord. And when you think about it, it just makes a lot of sense. So our Christmas tree always wants to be closer to those areas. And yes, there are definite times where we're running things above and below a vertebra, and then you're thinking, okay, we're on the spine. In that case, I'm not sure that it matters so much, but when I just keep it straight in my head, I always just put that polarized positive closer to my brain. So they'll always be on the higher up vertebra and then negative as we get closer to our tailbone. I hope that makes sense, and I'm sorry that we rushed through that before. But anyways, that is my segue from Robert Becker. And I'm sorry to anybody who thinks this was a fascinating read and got through it in a weekend. I do not think it reads like a novel. It put me to sleep. So that could be another segue into talking about sleep and recovery, which is what I wanted to talk about as well today. My next book is The Biology of Belief. Again, this is not a new book, and this is also a book that you will see at the core and at the advanced. Bruce Lipton does an amazing job about talking about cell membranes. And for those of us who have most of our science classes back in when we were like 13 and we talked about the cell and all the goodies that were inside the cell and we thought the nucleus was like everything, Not that science is changing, but we're changing the way we think about things. And cell membrane and the environment that the cells are in are more important. This actually gives us a lot of happiness and hope because we're not doomed by our genetic expression anymore. And if that were true, just because our parents had certain cancers or were predisposed to certain diseases, that would mean we were for sure going to get it. But we know that's not necessarily the case. And Carol talks a ton about gene expression and cell signaling and if we're doing a lot more research on the cell and the cell membrane and cell signaling, and we are combining it with FSM, this really could explain why so many of the benefits that we get from FSM seem to be permanent. So if you have not read The Biology of Belief in a long time, pick it up. I believe it's on Audible, and apparently it's phenomenal as an audiobook, which I'm also tempted to just listen to again because I tend to listen to podcasts while I drive. And so maybe I just need to get like a book on tape and hear it all over again. But this leads me
Get
to my
something else out
third.
of it when you listen to it audibly as well.
What's that?
I said, I think you get something else out of it when you listen to it audibly rather than reading it.
Yes,
So, yeah.
I agree. I think it's just like going to the core so many times. We get a little bit out of it every time we hear something new, and maybe our brains are just ready for more information. I know the first time I read The Biology of Belief, this was, I think, right when I got into FSM, and I read it and it didn't really resonate the way I was hoping it was going to. But when I reread it, and I only bought it because the cover was so pretty. The new cover is just, again, not supposed to judge a book by its cover, but it had the opposite effect on me. I really wanted to get it. So I got it, and maybe I was just ready to hear that information all over again. So these are two books that I think if you are just starting to get into FSM, or if you've been in FSM for a while and maybe you're now ready for that information all over again, those are the two books. The other person I wanted to talk about, because I think it's great to get a lot more information from different sources, is I'm gonna have to Google his first name because I just wrote down his last name. It's Dr. Levin, Levin. And again, Juliana Mortensen, I believe, had some of his slides in her presentation. Michael Levin. Yes, Michael Levin is a biologist. He's been on numerous podcasts. You really want to pick up some of his stuff that he's doing, again, talking about cell membrane potential. Bruce Lipton's, but a lot of data. He's doing some work with cancer right now. So I just wanted to put some of those continuing education and old books out there. Speaking of old books, everybody knows I have been a big affinity for these osteopathic books from the 20s and the 30s. And this started when I was doing my frozen shoulder presentation a couple years ago. And I wanted to, I guess I could hear the history of where frozen shoulder came from because I'm one of those people that for us to go forward, we have to go back and think, okay, where did these terms adhesive capsulitis even come from? What was the differential diagnoses? And that brought me to Dr. Codman. Now, many of us have heard of the Codman exercises. Those are the pendulums that we all do in PT where we're hanging. And I thought, I wonder if that's the same Dr. Codman. And I followed the rabbit hole down to like the 30s, and I heard about this book called Rupture of the Supraspinatus Tendon and Other Lesions in or About the Subacromial Bursa. These
I love that title.
osteopaths, what's that?
I love that title.
It's a big title. And I was going to say, these osteopaths were very wordy. And when I was putting this presentation together for that sports therapy course that I did a couple weeks ago in Newport Beach, I was trying to dig up a lot more history of FSM because that's what everybody always asks is, oh, this is a new modality. And you're like, no, it's been around for quite some time. And how did these osteopaths come up with these frequencies? I don't really know. But I love reading the research and the stories, and just I love reading the history of where these people were going back in the 20s and 30s with it. So in came this book, and I couldn't help but take notes. So here's a copy that was gifted to me. This is one of the first editions of Dr. Codman's book. It's in fantastic condition. I wish you could smell it. It smells like a really the old book smell. Oh, I love this. So the original edition, 1934. So when you read it, this is a surgeon that is talking in the first person. I was in the OR today, and this is what I came across. And I was like, it feels like almost like a podcast that he's sharing information back and forth. And the words that he uses and the phrases are very similar to the frequencies that we have. He talks about hemorrhaging all the time. I know the shoulder's not hemorrhaging, but it's just like when you nick a vessel, it will hemorrhage. And so the phrases I've been picking up from these old books, I think are very helpful to us using frequencies because we are using a lot of that verbiage. I think about the frequency, it's 58 and 2 or 58 and 32. It's abnormal cellular stroma. What is that? What does that even mean? And what does that apply to? And how can we use it? When I was teaching in Santa Cruz this weekend, I was talking about some of my other favorite frequencies aside from 40, which is 20, 30, and 50, how they go up in tens. And I think about the significance of those frequencies. But 20 is like pain and pressure, 30 is irritation. And part of me is wondering, is that physical pain or pressure, or could that also mean the emotional pain and pressure? So when I work with athletes, I hear all the time of the pressure that they have to come back. And part of me is thinking, do I run the emotional frequencies? Do I run that first part of the concussion protocol of nervous tension? Or will the pain and pressure that they're feeling psychologically and emotionally affect the pain and pressure in their knee?
All of that.
All of it, right? We don't know. So can't hurt might help. So I think like where I'm at right now in my practice is trying to find like the double meaning behind a lot of these frequencies and how we can also apply it. We saw that with hypoxia. It wasn't just not being able to breathe or the brain not getting oxygen. We can see localized areas become hypoxic. They don't get blood flow, they don't get oxygen. And so again, like what are these other meanings? Carol was using necrosis. Like, of course, the tissue hasn't died, but if it's not getting proper nerve supply, blood flow, if it's not getting all the things that it needs, maybe running that necrotic frequency can help breathe new life into it. I do think the osteopaths back then were a bit dramatic. I am going to say it. Like, I do think their words were a bit they were very wordy and it was a bit much. So if anybody out there has any other old books that they could recommend me reading, please put it in the Q&A or the chat today because I love reading this stuff so much. And I'm trying to like channel Dr. Codman, his presence, because I just think because we're using these frequencies from so long ago, we can really learn so much from going back and reading some of their manuals and reading some of the ways that they were thinking about something. I don't know. But as I was I was packing all my stuff up to go to Newport Beach and I was bringing the precision care and the custom care. And I thought, you know what, I'm just going to grab Dr. Codman's book to just have as a prop when I was setting up our little FSM display. And I threw some brochures just in the middle of the book so they wouldn't get wrinkled. And I don't think anything is a coincidence or by accident. So when I opened the book, this page jumped out at me and it was talking about 5 general guidelines for treatment. And this is for the shoulder, but he's also talking about in general. And so the number 1 guideline that this orthopedic surgeon from 1934 said, number 1, leave nature to do the best she can. That's awesome. And I think, how far have we deviated from that? Leave nature to do the best that she can. And it made me sad. I have a lot of great orthopedic friends that are big into biologics, and biologics meaning taking our own blood and spinning it and putting it back in to concentrate. I think that is a natural type of healing because we're not putting drugs or anything else into our body. And there is definitely a time and place for drugs and surgery. I'm not saying to avoid that because sometimes it is necessary. But I think what we do with FSM is we really are letting that number one leave nature to do the best she can, because we're not introducing foreign electricity. We're not zapping anything. We're
Focus
helping
on this.
ourselves help ourselves. What's that?
You're just saying, focus on this.
Yeah, this area is what needs attention and needs love. And yes, we treat the body as a whole, but if we're able to help nurture an area and support it and support its healing the best that we can, I do think that's what makes FSM practitioners stand apart from so many other people, because we're not just thinking of the tear in the joint or in the bone or whatever. We're thinking, how did it get like this? And if we can start thinking more and more, how did it get like this? That's what really makes us the most amazing practitioners. And yes, sometimes an injury is an injury. I had an athlete who tore his Achilles over the weekend. Sometimes a torn Achilles is a torn Achilles. It's a basketball game and there's no surrounding drama to it. But within that is, okay, sometimes Achilles tears are really bad and sometimes they're not so bad. And what makes one Achilles tear versus the other? Is it fascia? Is it the force? Is it like there's so many other factors? Just there's so many other factors that come into how do we heal the torn Achilles besides the obvious running torn and broken or repair and heal. Leaf has a couple things that are popping up here already. Look for anything written by or about Abrams. Yes, I am. The problem with, I think, some of these older books, The Process of Healing, I have already by Harry Van Gelder. Come on, anything by Van Gelder I've got in my book shelf. However, I also found The Process of Healing to be really complex and almost like a bit of a different language at times. And then Leaf is mentioning look into methylene blue as it converts methemoglobin into hemoglobin. Okay, methylene blue was talked about, I want to say, at the advanced as well. And I want to say Shirley Hartman might have been talking about it when she did her presentation a couple years ago. But I don't know how it works. Maybe I'll wait for Carol to talk about that, maybe, because I don't understand those pathways as well as she does. But going back to the shoulder and those points, leave nature to do the best that they can. Number two, because he's a surgeon, said to attempt bloodless reduction under an anesthetic. So even there, he is talking about trying to be as clean and as precise when he operates as possible. And I'm no surgeon, but I think there she is. I think when we talk about when something has bled, so there was my whole point of going into the hemorrhage frequency. Hi, I'm storytelling right now, so you're just gonna have to scoot in.
What did I miss? I've had good stories.
Yes.
I was doing a book report and I was talking about one of my favorite books was The Shoulder from Dr. Codman from 1934. And yes, I'm reading all these
An
old
oldie but a
books.
goodie.
It's an oldie but a goodie. And so when I'll catch you up super quick. When I had to go down to Newport Beach to do my presentation, I wanted to bring this book and some pamphlets about me in the clinic and FSM. And I shoved it in the middle of the book so I wouldn't lose it. And when I opened it, it was this very interesting page. And because nothing is ever a coincidence, Dr. Codman wrote about these kind of 5 pillars of treatment that I thought were just so poetic. And number one was leave nature to do the best she can. And as an orthopedic surgeon, I think that was like phenomenal. Sometimes things can heal. And so we're talking about healing frequencies. And then number two was to attempt bloodless reduction under anesthetic. And that was my segue into talking about when our hemorrhage frequency, that we talk about stop the bleeding and why maybe our post-operative frequencies are so profound is because this excessive bleeding that they were so worried about in the 30s, perhaps it causes much more chaos than we think it does. So just the hope and the effect that maybe running 18 gives us, I think, is very important. So that was my little book report. And of course, I had to talk about Robert Becker and The Biology of Belief by Bruce Lipton. And I also answered a quick question that I was emailed about polarity, that we don't talk about polarity enough. And
Oh,
so I just said Juliana Mortenson's presentation from the advanced, her first few slides had brought us back to those basics of Robert Becker's research showing that the brain, spine, and heart were the most polarized positive areas of our body.
whole center.
So the whole center.
Yeah.
And yeah, I guess we just take it for granted. That's where we put our positive leads. So I was just trying to say maybe we'll have more. I'll try to remember that a bit more because I just take it for granted that we talk about it enough, but maybe we don't.
Before I left to get my teeth cleaned and got stuck in traffic on the way home, I was doing emails and somebody was asking me about polarization.
Okay.
Why do you polarize a nerve? I said, nerves like to be polarized.
Yeah.
And the question was, what's the difference between polarized and alternating when you're treating a nerve? I said, polarized positive works faster, but alternating ultimately works because current is flowing from where the nerve starts to where the nerve ends, and it flips those voltage gated ion channels. And
Right.
with polarized positive, you always use that as long as you're for certain that there's no central or foraminal stenosis. So we just did a 2-day practicum over the weekend, and we don't do physical exams. We don't have imaging. And so the whole weekend is done alternating. I can't
Right.
take a chance on making somebody worse because
Right.
it upsets people. And
Right.
but in the real world, we polarize nerves, we polarize the spinal cord, we polarize anything that goes from the brain to the feet, like 40 and 89, things like that. That speaking of 40 and 89, this weekend, one of the practitioners came in and she had what you would call a that face, a sturdy, fierce, all business, tough, defensive, ready for
Yeah.
anything face.
Yeah.
And supine cervical practicum. And she said something along the lines of, it feels all smushy and I'm almost afraid to move it. Frequency for that. So we ran 40 and 89 and she just blissed out. So we put a second machine on her and ran concussion in Vegas. And the woman that got up off the table at the end of 52 minutes looked completely different. Like her face didn't look like the same person. And that was one of those things where you say to the patient, you've got to go look in the mirror now. Just go look because there's no way to describe. And she was like that all weekend. She
Wow.
she bought a custom care and a magnetic converter that day, had me program it, and I increased the amount of time for 40 and 89 to 30 minutes because of some things she told me about childhood trauma and recent trauma where she lost her house and everything in a flood that wasn't her fault. And then increased secretions in the vagus ran instead of for 4 minutes, ran for 12 or 15 minutes because the vagus is what tells the midbrain that we're all fine down here. I don't know what you're worried about. We're fine now.
Yeah.
And that was, and when you run 40 and 89 from neck to feet, polarize a positive. But I love your book report. That's
They're always in the background, and I carry the Codman book around with me just because I love the way old books smell. I love old bookstores. It's just, and like I said, I'm trying to, I don't want to say relearn, but when I went down to Newport Beach, I presented to people who have never heard about FSM before and how challenging that was for me, and how grateful I am for that presentation that you had sent me, because it has a lot of that early sort of history, which I think is very important to introduce FSM with. And yes, the locks and cocks and the cytokine data and the DOMS papers and all the testimonials I have from my athletes are impressive. However, people will say, oh, this is that new blah, blah, blah. No, it's not new. This is not new, and I deeply respect the numbers and the verbiage that were passed down to us. And when you read some of those old medical textbooks, you understand why the frequencies and the descriptions sound the way that they do. You understand hemorrhage. Like, they're very dramatic. Like, Dr. Codman is so dramatic when he writes about his surgeries. And so I think that does just help us understand those terms like abnormal cellular stroma that we see. Like what is that?
Yeah, the language from the 30s and the descriptions from the 30s. And you have to remember that anesthesia was not developed until 1900.
Yeah,
In the Civil War in 1860, 1870, in there was no anesthesia when they were amputating legs. So general anesthesia was not safe, made people throw up, and the surgical techniques that we now take for granted. So in 1934, you had one surgeon operating by himself,
right,
with a nurse and an anesthesiologist who's got a screen with gauze and ether. So
right,
fluothane and the other halothane anesthesias weren't developed until the mid 40s, early 50s. And the technology, the practice of having one guy, a nurse or a doctor, whose only job is to suction the bleeding and
right,
cauterize the bleeders. So they didn't have cautery in 1934.
right,
Cautery was developed I think, in the late 40s, early 50s. There was a lot of development of surgery because of the Korean War. And
okay,
then the 70s, when I started being a drug rep, I was trained by physicians, trained. They really did. They taught me how they were doctors. But they were trained before there were antibiotics. Think about what surgery was like before there was high pressure sterilization and antibiotics and cautery, and one guy as part of a surgical team. So there's one guy whose job it is to just get things out of the surgeon's way. There's another guy whose job it is to suction up the blood. And then there's the surgeon whose job it is to not cut stuff that he shouldn't cut. And back in 1934, there was one guy doing all of that.
right.
It's just,
So the care that they needed to make sure that they weren't, like I said, he talks about hemorrhaging all the time. And right, because he didn't have a team of suckers and stitchers and all the things. It was on his clock, on his watch to be careful.
yeah, no,
And
it's,
that's how I think of myself when I practice. I'm mindful of all the things that affect that person's condition. And, how we talk about, yes, there's an A channel and a B channel and the pathology and the tissue, but the real success, the real results, the real magic happens when it's, how did it get like this?
Yeah.
That's what leads us to the frequencies that tell the story of the condition. And it's not just scarred. It didn't just
That's
refuse to believe
bleeding.
that.
Bleeding causes scarring. And then I had a patient that there's a phrase, it's a webinar I'm supposed to do. It's called clinical correlation. Is that it? You were supposed to keep track of that.
Sorry.
It's clinical correlation. So the history, the physical exam, well, the symptoms tell you where to go look in the physical exam, and the history is what talks to you about the causes. And I had a patient who's a tennis player, and her symptom was she'd be playing tennis and her legs would just give out.
Okay.
And my first reaction was, she's got MS. They'd already done MRI with contrast in the brain and the C-spine, and then I looked up. Any place between 17 and 36% of MS is thoracic lesions. And it's okay. Then she came in and they had all this stuff, and I did a physical exam, and we came up with a concept of, she stood up off the table after I did her physical exam and her toes turned purple. That's not normal. And then I wonder if, did you get COVID? You did get COVID. Huh. And Vex. Huh. And then yours and people at the symposium, all the description of what COVID does to the inside of the blood vessels. So that treatment was all blood vessels, just torn and broken, increased secretions, vitality, and the blood vessels. Second visit, I played a match and no weakness, and my legs didn't fall out. Well, that was good. Her other symptom is she wakes up in the morning and her legs are really achy and stiff. In a 16-year-old kid, that's not normal.
Right.
So she's laying on the table and I'm going to treat her blood vessel scan. And I start palpating her quads. Her legs are achy and stiff. And her pectineus and her brevis are really tight. And she has no body pain, just tightness. And her hamstrings are like guitar strings. We have a solution for that. So neck to feet, 81 and 10. At the end of 60 minutes, her legs didn't ache anymore. And it's like they had an MRI of the C-spine, but they were looking for MS. They weren't looking for disc bulges. We got a copy of the MRI, and there it is. She has a purely central. It's here. It doesn't go out, no finger pain, completely normal sensory exam, but it's central. Disc bulge at 5, 6, and 6, 7. She's a tennis player. And the other key part of that history was, how do you sleep? On my stomach. And that meant her head was turned to the right most of the night. And that meant that the jelly donut was doing this to those two disc bulges. And the proof of the concept is, does 81 and 10 work? And it did.
Right.
She got up off the table. She said, I don't know how to walk. My legs are all squishy, all soft. Isn't that cool?
How long do you think 81 and 10 should generally be run for? I know that's I understand how it sounds when I ask this question,
No,
I
no,
never think I run it long enough.
no, it's 60 minutes. It's just
Yeah.
flat out. It has never been less than 60, maybe 50 if you're lucky. But it has to have something to do with the homunculus in the motor pathways in the spine, because every time it relaxes up the front and then starting at the feet, it goes up the back. And when
Right.
hamstrings relax at the knees and the low back muscles relax, it's done. The other thing
Yeah.
that worked on her was I checked her psoas the first visit, and that was the first thing I did. So for her successful tennis match, the thing that she said was, I could take a deep breath.
Wow.
I couldn't before.
Yeah.
But you work on the psoas and the QL, and they can take a deep breath.
Right.
Isn't that cool?
It's very cool. I think one of the coolest things that I put together very late in my FSMing career was that 84 is the diaphragm and it's also the hindbrain.
Have you figured that out? Because I just took 84 out as the diaphragm because I don't believe it, because it works so well as the cerebellum. How could they be the same thing? And the diaphragm is innervated by 3, 4, and 5.
Yes, and but to me, they all work together. Like I just think of brain and breath. And then if you're treating the diaphragm, you're treating the vagal nerve. And so there's that too. So I just feel like it's a slap in the face. You need to like wake up, and as you're treating the nervous system, you have to work with breath.
Yeah. Yeah,
I just see the symbolism there, but I know it's
I get it. It's got to make sense somehow. But the magic for me with the psoas, the kidney, and the kidney fat pad is psoas weaves into the diaphragm from the front, and the quadratus lumborum weaves into the diaphragm from the back. And if
Mhm.
they are both slammed shut and not moving, they can't take a deep breath. So it's yeah. It's-
One of the things that we do just like inherently is when muscles start to relax, and we see this on our patients, they take those deep breaths. There's a
Truth.
sense of relief, right? We take those sighs too. Andrew Huberman is doing a fantastic job with all of his podcasts about breath and sighing and the double sniff and the extra sigh. All of this works with diaphragm, central nervous regulation, getting our vagal nerve to do its job better. So I'm doing a lot more with breath work towards the end of a treatment to, I think, tie it all together. So many times when I'm just doing a post-treatment standing assessment, or we're doing our reboot or rewire, whatever people call it, wipe and load, the first thing I want to do is just stand and take a couple deep breaths, get in your body again. And I, so maybe there is something to the brain and the diaphragm being similar.
It could very well be.
And sometimes I think just don't overthink it.
Yeah, it's once the periphery works differently, the wipe and load 40 and 89, stop being afraid to move it. And
Yeah.
then your sensory and motor cortex has no idea what these muscles are like, and then the cerebellum has no idea how to coordinate movement. So you
Right.
put all that together. There was another thing that happened at the practicum this weekend, and that was during the second day in the afternoon when we do 2 free-for-all practicums. They get to do the supine lumbar and whatever. They learned about FSM as truth serum. So they're working on somebody and they start doing whatever they thought they were going to do. And as the patient gets a little bit floaty, the patient says things like, "Oh yeah, I forgot to tell you I broke my arm twice." And that's okay. "I forgot to tell you I had this auto accident." It's
It is so true about the truth serum. It's so funny.
Endorphins
But I
are a
love it. It's
wonderful
like,
thing.
and teenagers are so funny. I've seen so many like very stoic young men come in, and when they have a little bit of frequency, they turn into like the littlest chatterboxes. And I had one mom the other day that was like, "Can you ask him if he has a girlfriend? Because he talks so much when he's in the room with you." And I'm like, I'm not going to be your Secret Service agent here and try to get things out. If it's not relative to the knee pain, I'm not gonna ask about it. But it was just, it's
That's-
very, I think we have a couple questions that have snuck up on here. So
There's-
somebody used a foam roller on the low back and SI, and now the lower back has some shooting pain when they walk.
Here's, yeah, I'm so proud. You said, "So I gently used a foam roller, insert stink eye, yes, in a class today on my lower back and SI joint area." There's the stink eye is the oxymoron that is gently used a foam roller, because you have your body weight laying on top of the foam roller, gravity, and anyway, lower back and SI joint. And now my lower back has shooting pain when I walk. If I had to guess, I would guess that, I don't know whether you on your side or on your back, but shooting pain when you walk is either a meniscoid in the L5S1 facet, or you sprained your SI joint. That's shooting is the key. So then the SI joint is, it hurts when I sit, it hurts when I stand, and I can't roll over in bed. So if those three things are true, you sprained your SI joint. If you just have shooting pain when you walk, that pesky foam roller somehow compressed and squashed and annoyed your probably L5S1 facet joint, and worst case scenario, jammed the meniscoid. So it's a little flap of tissue that attaches to the joint capsule, and it fits in between. So the joint capsule is here from the top to the bottom of the facet, and the meniscoid is there. And just when I walk, great, then it's either just the facet if you're lucky, and that's probably it. You just jam the facet. So treat acute or subacute facet. What do you think, Kev?
Yeah, typically foam rolling doesn't have to be bad, and I definitely will prescribe it within reason with a really soft, squishy foam roller. And there's a definite sequence in which we want to mobilize fascial chains and muscle tissue. You can't just jump on certain areas and squish them with hard foam rolling because you are going to irritate areas. If she did release something that was quote unquote tight, you are depending on your position with the SI, yeah, that SI sprain, or if she had a torsion, she could have made that worse. Just the way that sacrum is sitting in the ilia, you irritate it. So with walking, when the ilia are supposed to move nicely with the sacrum, if something is off, you're going to irritate it. So the facet is going to get irritated. So I would agree with you, like those frequencies for an SI type sprain, facet acute would be helpful. But I would be very careful with foam rolling. I think I have just clinically seen it's the same way with you. There's certain treatments that make you like cringe because you've seen when it goes wrong. I have seen so many injuries from foam rolling and massage guns.
Oh God.
People, people just those heavy crate, not even heavy. You can even get the cheap ones on Amazon that cause pain because people are putting too much activity or there too much percussion on tendinopathies. They're making things much worse. So
Bleeding.
bleeding, yes. And I would target foam rolling is very effective in a good way and a bad way to fascia. So I would do a lot of fascial frequencies because of just that matrix that gets disrupted with aggressive foam rolling. Even though she said it was gently, sometimes it's just hard to be gentle in an area where there is scar tissue or congestion and you release something.
And my position about fascia, it's innervated. Fascia does not exist on its own. It
Yep.
is not a thing. It's innervated.
Yep.
It's in all the books, and the
Yep.
fashionistas, the fashionados, I don't even know what to call them. It's like they seem, you have an empathy with the fashionados, so maybe you can educate me. They seem to think that the fascia exists independent of the nervous system, independent of underlying pathology, which drives tone, because the fascia forms sort of sleeves around the muscles. It's everywhere and it conducts really quickly. So when you start pounding on fascia or even stretching it,
Yeah.
it's it I don't understand it enough maybe, but when you do that to it, the nervous system takes offense. It's
Yeah.
this is dangerous. Stop it.
Yeah.
And
Yeah.
so the fascia is going how I don't get it.
So I've been the last year, I've been taking really deep dives and learning because I feel the same way as you. I grew up on that biomechanical model. I grew up appreciating fascia, but I don't understand some of the points that you were saying.
Oh, good.
Mo-
So it's
I
not
think
just me.
it's not just you. No, I mean, I think mobilizing fascia is like mobilizing connective tissue. It has to be done with skill, it has to be done with respect, and it has to be done with safety. So, to
Slow.
your point, flow. So we want that the smush that we talk about with FSM is thixotropy. Thixotropic changes happen when fascia as ground substance allows that slick and slide to move between structures. I think that's something we can all agree on. It's always a good thing. But to your point, when you jump on tissue, when you are aggressive getting aggressive manual therapy treatment, when you jump on with a foam roller, when you get a massage gun, the nervous system not only takes offense, but it goes into high alert. There is no way you're going to get that thixotropic smushy change because of the threat that's happening to the tissue. So everything tightens up. And I understand fascia can't contract as far as the model of the sliding filament mechanism. There is no actin and myosin in fascia. However, it is this matrixy web that can get very constricted when there's danger and then when there's threat. So that is what
When
I think is
underlying pathology that it has to protect. And
absolutely.
that is guided, I think, by the nervous system. And I think that's where FSM has such an advantage
Yeah.
over almost anything for treating fascia because we fix or treat or address the underlying pathology. When we do the supine cervical practicum, we treat all the underlying tissue. And when we get down to the very last line and we treat hardening in the fascia, then I ask the whole class, does that change anything? Just for the fashionistas in the group,
Yeah.
does that change anything? It's no. And they're very confused. And I said, now try 81, increase ground
Yeah.
substance. And just when you thought everything couldn't get smushier, the fascia goes, oh, thank you. And
Yeah.
melts. It's
It melts. Yeah. And there is a we were talking about it. We had the sports course in Santa Cruz this past weekend, and it was so much fun. It was a very like heavy physical medicine, as most of the sports courses are. But we were talking, we had somebody from Canada who's trained on the osteopathic model, and we were talking about the term vitality. And I have been really playing around with doing vitality first, sometimes in the treatment, not just finishing with it. And again, I have Roger Billica's voice in my head. Sometimes you have to put in more good before you take out the bad.
Okay,
And
I
so
feel like it's saying take out the bad stuff, then put in the good stuff, but it could work.
historically that is the rule, but I remember him saying very clearly sometimes the exception, especially if somebody's very, and he was talking in the cases of somebody who's very sick, has a lot of disease, you have to bolster that immune or bolster that stable state before you can pull some stuff out. And I think that happens with fascia. Sometimes you have to give it more ground substance, give it more the thixotropic change, really fluff it up before you can start getting deeper and finding the scar tissue or the pathology somewhere a little bit deeper. That's just what my fingertips feel and see.
Yeah, it's these, and it's the fluffy is such a nice word. I like fluffy.
Yeah, I have a slide now that says the floof phenomenon, and that's what I feel. Just when I get really sciencey, then I have to call it something like the floof phenomenon. But when it's the smush is different than fluffy. Like
Oh,
it's a
totally.
very feel to the tissue when things start to fill up again, especially when we're talking about tissue that's hypoxic or necrotic, or that's where you can really feel that beef jerky tissue start to, I don't know, fluff up. I can't think of it any
There's,
different than
there's,
that.
given what we do, and what we feel, there's no other technique that I know about that will do that to so much and so many layers of physical tissue at
Yeah.
one time. It's, yeah, the patient I saw yesterday, 90 years old, and his right leg is from the knee down is in like +2 to +3 pitting edema. Ankles are this big. And come to find out, speaking of surgeons, he had varicose veins. And so the solution was to inject something into the vein. Now, they used to even just take a little laser and tighten the vein up by causing sclerosis, running a little laser up at it. No.
Okay.
They injected a chemical into the vein or a substance into the vein. Patient didn't know what, but that dissolved the vein.
Okay.
And when he went back to the surgeon and said, "Hey, look at my leg. It's like this." And the surgeon said, "I took out 4, probably should only have taken out 3." Oh, okay. And we got the swelling down. I will find out tomorrow if it stays down. And the other leg had cellulitis up by the knee. And the bronzing that happens in diabetes is 90
Mhm.
years old, completely healthy, no diabetes, but his leg is brown. And we have a frequency in diabetes, it's called bronzing.
Hmm.
But I think of it as the iron in red blood cells that can't get out. I don't know if that is correct. Do you know anything about bronzing? No.
No,
Okay.
your hypothesis is interesting to me.
So we have a frequency for iron, and it's
Right.
brown skin, and he's got almost no swelling in that left leg.
Right.
Brown, dark brown,
Yeah.
brown skin. From the knee to the foot, I ran the frequency for iron in the skin. And I expect things to change from the top down.
Yeah.
We sat there and watched his skin change color from the bottom up. So
Wow.
his daughter's there watching, and I looked at his leg and went, "Do you see what I see? That wasn't that color. How did..." So
Yeah.
everybody wants to try 5, which is iron, and skin, but we know
Interesting.
Carrie Bullock, killer class on Sunday in Santa Cruz, back in Colorado. Oh dear. Santa Cruz to Colorado, that's a tough one.
We had a great time. Big shout out to our host who had such a great facility for us to play with. And I love all the props, all the balance pads, and all the goodies we got to play with. And I just think it's every time I teach it, I'm so grateful for the opportunity. It's just so much fun for me, and just to see the ideas sparking from other people. I think that's what it's just really about, is critical thinking. So
And they
yeah,
get to take what you teach them and put their hands on. I'm gonna answer Lisa,
yeah,
and then your
yeah,
alarms are going off. I was
yeah.
told I had torticollis when I was born via C-section. Left side of my neck and top of the shoulder have been tight for many decades. The torticollis is the SCM, and the SCM is the accessory nerve, and C1, 2, and 3. And sometimes when a C-section is necessary, you they they make an incision that's this big down by mom's pubic bone, and usually the uterus, like the external incision can be, this is always this way, but the internal can be this vertical or horizontal. And then they reach inside the uterus and pull the kid out by whatever presents itself. And that's usually the head. So what I would try is, we call the concussion protocol, I'm sure you've already run, but just straight up 40 and 94. And you have to wonder, we saw so many nerve traction injuries at Cleveland Clinic from birth, where the
Mhm.
shoulder gets stuck and you get a brachial plexus traction injury. But when they have a C-section and they pull the kid out by grabbing its little head, you're gonna pull on things. So
Yep.
I'd try torn and broken in the ligaments at C1,
Yep.
and 40 and 94, 94 and 94, torn and
Yep.
broken in the ligaments, inflammation in C1, 2, and 3.
Yep.
What do you think?
I would agree. I'm trying to think if I don't know if I would add anything at this point. I would try those for sure first.
Yeah, it's,
Interesting.
you gotta love, it's 4 o'clock already.
It's 4:02. Tad likes the observation about iron in the skin, and he's going to try it. And Leaf, you're very welcome, and thanks for all the book recommendations, because I put it out. If there's any other old books from the 30s that anybody thought I would like, I would love to hear them. I'm still finding more and more nuggets from Dr. Codman every time I open up a page. So
That's so cool.
it's like it's like learning a new language and trying to just go back and hear things maybe a little bit differently.
And appreciating how they thought
Yeah.
before they had ICD-10s, insurance companies. In 1985, when managed care took over medicine and medical education, everything changed. I left pharmaceutical sales in 1986, and it was just a fine time to get out, because medicine totally changed when it became, what can you get paid for?
Yeah.
And what, and they developed, the insurance companies developed recipes. This diagnosis means that drug. And back in the 30s, 40s, 50s even, when you read even the papers that they wrote, it was more critical thinking. It wasn't a diagnosis drug. Now, when you read medical papers that are written in the last 10 to 20 years, it's nitpicking about which drug does what and how, and it's a whole different thought process, even in the publishing of papers. Yeah, stuff written in the 40s, though, won't apply to your clinical practice so much, but you get to appreciate the way they thought before medicine changed in 1985.
Yeah.
It's so cool.
I think so.
Yay.
It's not cool that it's the end of our podcast, but we'll be back next week. So
I'll be back next week.
we'll just pick up where we left off.
And next week, I'll be in time.
I'll just do another book report. I've got a whole bunch of things to talk about always.
I knew you would, which is why I didn't mind getting
It's exciting having 15 uninterrupted minutes all to myself. So anyways, thanks for indulging me, everybody. And we'll see everybody here, same time, same place next week.
See you next week.
Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.